Hey, good afternoon, everyone. Firstly, I would like to thank all of you for joining us today for the webinar. We have planned this webinar to help you understand the quality payment program with focus on the ACI component. So today we cover three components of QPP. We cover the advancing care information, quality, and the impact of improvement activities on EHRs. So we will be focusing on these topics with respect to the 2015 certification. During the session, we will have a brief pause after completing each slide to answer any questions. If you have any, you can select the hand icon in the side panel of your GoToWebinar and we will unmute you and get your question answered. However, if there are any questions that are not answered during the course of the presentation, we will have a 10-minute Q&A session towards the end. So I would first like to introduce Vijaya, who is our presenter today. So Vijaya is the subject matter expert for US healthcare at Nalashaa Solutions. She has been assisting and working closely with a few number of EHRs for Meaningful Use Stage 3, as she did for Meaningful Use Stage 2 certification. All right, everyone, so sit back, relax, and I hope all of you have a meaningful session and in the end have some takeaway from this webinar that will help your plans around this endeavor. Over to you, Vijaya.
Thank you, Sam, and good afternoon, everyone. My name is Vijaya, and I have been helping EHRs to meet the regulatory compliance and making it more meaningful for the clinicians. Welcome again to the webinar today. We are going to primarily focus on the ACI component of the quality payment program and the certification requirements that every EHR would undergo. So let's start with what is quality payment program. So quality payment program focuses on better care, smarter spending, and improved outcomes. While QPP delivers high quality care, it also rewards values and outcomes to physicians. So this program combines legacy programs into a single improved reporting program by two ways. One is advanced APMs and the other one is merit-based incentive programs. So advanced APMs is nothing but a subset of APMs where the physicians can apply to a specific clinical condition or care episodes. Few of the models that fall under advanced APMs are CPC Plus, Next Generation ACOs, Oncology Care Model, ESDR, and the Shared Savings Programs. So there are a few other models that CMS is working upon to add in the advanced APMs. Before we move ahead with MIPS, that is Merit-Based Incentive Program, let us take a look at what is the eligibility criteria for QPP. So any physician who bills Medicare more than $30,000 annually and who sees more than 100 Medicare patients is eligible for this program. Besides physicians, even the nurse practitioners, the physician assistants, the clinical nurse specialist, and the CRNAs can participate in this program. This is the reason the participants in this program are called as eligible clinicians. Now let's go ahead and see what is under merit-based incentive program. So merit-based incentive program comprises of 4 different components. The first component is advancing care information, which replaces the EHR incentive program, popularly known as Meaningful Use Stage Meaningful Use. The second component is quality, which replaces PQRS. There's a third new component that is improvement activities, and we have the fourth component, component that is cost, which replaces the value modifiers. So MIPS ties together these 4 programs under one umbrella and gives equal weightage, for each of this category to add up to a composite score of 100%. So this is a visualization of how legacy programs streamlines into the MIPS performance categories. So for this, for 2018 reporting period, all the EHRs have, the clinicians would have to report using the 2015 edition certified EHR. Before we move ahead, let us take a short poll. Okay, you'll have a poll on your screen. This would actually help us conduct a survey, and we would share these poll results with you. Thank you for answering the poll. So the way we have segregated all these requirements is based on the modules that get affected with the EHR. The first one we'll start with is the patient information. So under patient information for demographics, the new changes are we have two new fields here for sexual orientation and gender identity, which is actually a crucial first step forward to improving the care by CMS. Besides this, EHR have to now adopt to a more structured and granular recording for race and ethnicity. So CMS has introduced use of both OMB and the CDC standards for recording the race and ethnicity. Optionally, EHRs can also make sure that they record to social, psychological and behavioral data, which would be a list of questionnaires related to 8 different domains, and this would more relate to the mental and behavioral health EHRs. The new measure that we see here is the implantable device list, where EHR have to make sure that they have an ability to exchange, record and allow a user to access a list of unique device identifiers, that is the UDIs, associated with the patient's implantable device. Also, the ability to parse a UDI into these components, they are the identifiers. So this integration needs to be done with FDA's Global Unique Device Identification Database, that is GUDID, and as a response they would send the details of that implantable device, say the brand name, the model number, the expiration date. So all this can be captured and shown to the physicians within the EHR. We have the updated newer version for SNOMED City for problem list and family health history. The second new measure that we have in Meaningful Use Stage 3 is the patient health information capture. So to ease the linking between the document storage, with this measure, CMS makes sure that EHR has the ability to identify the patient information directly or electronically shared by the patient. So this can be achieved either by providing a reference. So this reference can be a narrative information of where actually that specific document is located, or it can be an ability to link to an external internet site. So if a document is say on a cloud storage device, where and this can be viewed by the provider within the EHR. So no standards are defined for capturing these links, just a common place where which is actually going to help providers to know all the available documents within that location. That's about the patient information. The next thing that we'll target is the interoperability. So before we move ahead with interoperability, we have few gap measures here. So with 2014, if you are already certified with 2014 edition, you do not have to go ahead and recertify for these measures which are related to the base EHR criteria. Let's move ahead with interoperability. So CMS has made sure that it prioritizes interoperability, seeing the challenges being faced by many EHRs or many healthcare systems in the healthcare ecosystems with the ability to exchange the information. So with interoperability, the first thing that strikes everyone's mind is the CCDA. So CCDA, as we all know, is a one-stop source to see the patient's most recent clinical information. With 2015 edition, it now goes more seamless, and CMS proposes to use this newer version. It also So EHRs would also have to address the bilateral asynchronous cutover, which is nothing but EHRs should be conformant and capable to create and parse both these versions, that is 1.1 and 2.1. That is, you have to be backward compatible for the CCDA standards. So with this, with 2015 edition, we also CMS has also defined all of these sections, different elements within the CCDA as a common clinical data set, as you see as a heading. So this common clinical data set is nothing but an upgraded version of common data set that we had in 2014 edition. So common clinical data set would have few new sections as compared to 2014 editions, and they are the implantable device list that we just saw in our previous screen. Then we have goals and the health concerns. Besides this, there are few optional ones like the BMI percentile recording and few of the vitals. After this, the new change that we have in CCDA is a complete new care plan document. So with this care plan, it actually is going to bring in value for improving the coordination of care, and it also provides a structured format for documenting these information. So what these care plan is going to contain is your goals, the health concerns, the health status and evaluations, and the interventions. It represents a consensus-based approach, and I believe it is the best approach available today for capturing and sharing the plan information. Besides this, while we talk about sharing of information, the CCDA is normally being exchanged currently using the direct methodology. So if most of the EHRs already are using the EDGE protocol, if not, that is new for us in 2015. When we talk about exchanging of information, there comes an idea of security. So how secured is the data that is being sent? And what if the patient doesn't want to redisclose the information? So for this scenario, what CMS has done is they have come up with a new standard, that is the data segmentation for privacy, that is DS4P, which enables this sensitive health data be exchanged and comply with the state and the federal laws. So that is actually going to protect the sensitive data being shared. So this is up to the patient to make sure that how much they are going to withhold the disclosure, or actually they can place the restrictions on this redisclosure of the patient information. With that, we also had another measure called as data export in 2014 edition. So with data export, what is new here is they have come up with a time frame configuration. So by time frame configuration is nothing but ability to have real-time data access. There should be a storage where all these CCDA documents can be exported to, and for a specific date range, say I want to export all the CCDA document on every first of every month. So this is the process that is going to happen with this measure. Now when we talk about sending of the CCDA document, there was a design that was implemented to complete this electronic transmission loop and also help the clinicians in using the EHRs to support this multiple roles of that a clinician actually plays in exchanging the health information. So they came up with information reconciling, that is incorporating this CCDA into the patient record. So we had those three elements, that is our medications, allergies and problems that we supported with 2014. With 2015, we still have to support these three elements, but these three elements would be would now have to support with the newer version, that is 2.1. So I do see there's someone's hand being raised, but give me just few minutes. I'll just complete this slide and we can take up the question. So this communication for this reconciliation can actually be passive or active. So what I mean by passive is clinician is sent a CCDA and it is incorporated within the EHR. or active, where a clinician requests for a direct transfer of the CCDA, or clinician is actually going to query the health information exchange to receive the CCDA document. So this exchange can be done using the APIs. So I'll talk about the APIs in more details in our next screen. But when the incorporation of the CCDA happens, there were issues that most of the EHRs saw, most of the providers faced when they were upgraded to 2014 edition, that they used to see blank data in the medication, say brand name or something. The reason for that was everyone did not follow the same structure of storing the brand name. So few of them stored it under the name node, or few of them stored it under a text node. So this caused the confusion, and the physician could not address that. The physicians were struggling with that, and they're clueless about what is actually happening. So to resolve this, what CMS has done is they have made sure that they pass, detect, and notify users about these errors. So basically, what EHRs have to do here is they have to identify a valid document template. So if the document is valid or not, process the data elements within that document, and correctly interpret empty sections and null combinations, and be able to display a human readable format for the physicians. So before we move ahead, let's take a question. So I think we have a question from Carl Rai. Yes, Carl, please go ahead.
Hi, am I audible?
Yes, you are.
Yeah, so my question is, how exactly is the CMS going to assess the performance?
So are you talking about performance of the ACI component?
Yeah, exactly.
Okay, so for the ACI component, what CMS has done is for the physicians to score, they have segregated these measures into different components. First of all, they have to make sure that they are using a certified EHR. Secondly, they have to make sure that they actually completely report to the base score measures. So there are 5 base score measures in 2015 edition. And if they want to earn brownie points, they can report to the performance score measures and the bonus score measures. So the performance score measures, there are 9 performance score measures in 2015 editions. So out of those 9, so if you report the base score, you're going to earn 50 points. And for reporting the performance score, you're going to earn, if you report to 9 measures, you're going to earn at least 90 points. So that is above 100. So if the score is above 100, CMS is going to cap the score to 100. And besides that, there are bonus score measures for the PHAs and the improvement activities that they report to. So this additional bonus score can be around 15, will be 15 points. So a total of 155 points. They can earn maximum 155 points, but yes, it would get capped to 100. Does that answer your question?
Yes, it does.
Thank you so much. So let's go ahead and to our next slide, which again focuses on interoperability, and this is the data access. So for data access, there are 2 things here. So data can be accessed either by the third party or by the patient themselves. So by third party, I mean we have a new measure here, that is application access. So application access is nothing but EHR has to demonstrate that they have the ability to exchange the data between 2 systems. So a third-party system can read the data from EHR using an API. So by providing the API functionality, it is actually going to address many of the challenges that are currently being faced by the physicians. So this can include your multiple portal problems. So multiple portal problems is potentially actually potentially allowing individuals to aggregate this data from a multiple web sources, and so patients can choose which portal they can use and access data from all different EHRs, so they can get the complete data and know how the care is happening. So this is also going to provide flexibility for the EHRs because implementing of APIs would also mean it is allowing the developers to leverage the existing standards or come up with new standards. So what's the new standard here is, as you see in the brackets out there, so ONC recommends us to use the FHIR standard. So FHIR is nothing but Fast Healthcare Interoperability Resources, a new standard by HL7 which beats the issues that were there in the HL7 or the CCDA, and now comes a step ahead, and this uses the RESTful based API which is specially designed for the mobile applications. So EHRs must now be able to demonstrate this use of APIs, and this can be done when, the basic criteria of this measure is when a third party is requesting some information from the EHR, it would send a request, the EHR sends a ID or a token as a response for the first time to the third party, and the subsequent request would be sent by the third party using the same token or the ID. So this ID can be the patient ID. So if it's a patient portal, so the unique identification of that patient is through the patient ID. So this is nothing but your OAuth 2.0 implementation, where you have your authorization server, the authorization is done, the authentication of the client is done, and the response is received. So besides, yes, of course, this new API implementation, if the third party needs to access to this new implementation, they have to make sure that they document the accessibility of the API. So basically add the syntax and semantics of the APIs and make it publicly available so the third party can read the data. So what all data can be read is first can be your patient information, then the discrete common clinical data set, that is individual sections. So with FHIR resources, there are different resources for every common clinical data set, and the third one will be your CCDA. So currently we already have this implementation of CCDA using the direct messaging. So with APIs, we also have to perform the complete documentation for the CCDA to be sent to the third party. So any interactions that happen between these two systems also needs to be audited. So that was about the application access. So a completely new one, and a strong criteria for interoperability by CMS in meaningful use stage 3. So there's a minor change for view, download, and transmit here. Of course, we have to now support the newer version, that is 2.1, and also make sure that the data is available in real time for the patients. Then we have the patient-specific education. So for patient-specific educations, we have the updated InfoButton standards that is release 2, and also associated implementation guides are updated. And so in 2014 edition, we also had lab test. So there were 3 elements that got affected. That they were the medications, there were the problems, and the lab test. So with 2015 editions, lab test is actually not mandatory to be implemented for patient education, because CMS does understand that the InfoButton standard cannot be fully cannot actually fully support this level of data specificity. Then the third one is the preferred language. So for preferred language, yes, this was an optional feature in 2014 edition also, and remains optional even now, but that is actually going to help provider the patients for an improved care and understand their the diseases that they are facing. Let's move ahead and see what's next is the privacy and the security measures. So not major changes over here. We see there are some changes in the user privileges for auditing. For integrity, we move ahead from SHA1 to SHA2, or you can even go higher to SHA3. And for trusted connection, this actually mirrors your API implementation. And even your patient health information capture, that should be done using the trusted connection. So there are these are the gap measures that we had in privacy and security, and For that, again, as I said in my previous slide, you do not have to get recertified for it. And one more thing about the privacy and security, so this does not fall under the cert definition from 2015. Before we move ahead to our next slide, we have our second poll out there. So please go ahead and answer it while I catch some breath. Thank you. Thank you so much. Let's move ahead and see what's in public health agencies. So the purpose of the public health agencies in stage 3 is to further advance the communication between the providers and the public health agencies. So they want to strengthen this communication and capture the health information within the care episodes. So they have to make sure, so whenever the CMS has come up with a text explaining the requirement for the PHAs, they have made sure they have actually written it that eligible clinicians need to be in active engagement with the PHA or the clinical data registry to submit this electronic health information in a meaningful way using a certified EHR. So this notion of active engagement actually replaces the prior ongoing submission, and it refers to a process by providers to actually send the production data to the PHAs, and PHAs respond back to the providers. So there is a communication between both of them. Initially it was always a one-way communication. So this two-way communication, when it comes into picture, CMS has made sure that there are options that the providers have to go ahead with. So there are 3 options that we have. Option 1 is a completed registrations to submit the data. So providers have to make sure that they get registered with these PHAs, and it needs to be completed within 60 days after the start of the EHR reporting period. The second option that we have here is testing and validation, where providers have to make sure that if they receive a response from the PHAs or the CDRs, they have to respond it within 30 days. So failure to respond to this is within the EHR reporting period would result in that provider not meeting the measure. The third option that we have is yes, sending the production data actively to the PHAs and the CDR. Now let's go in detail for all these PHA measures. The first one that we have is immunization registry. Yes, it still remains a priority because exchange of information between your certified EHR and the immunization registry actually allows a better patient care and provide an informed decision for the provider. So we have an updated implementation guide, that is version 1.5, where EHRs should have the ability to receive and display a consolidated immunization history and forecast in addition to sending the immunization record. Besides this, EHRs have to make sure that they support the NDC coding system. So with 2014 edition, we had support to only CVX coding systems, but with 2015, we have to make sure that EHRs support NDC coding systems also. So yes, you can go, providers can go ahead and send CVX codes for the historical immunizations, but for the newer immunizations, they have to use the NDC codes. There is no requirement as such that CVX and the NDC codes need to be mapped. The second measure that we have here is the syndromic surveillance. So for syndromic surveillance is an optional measure now for ambulatory because CMS does understand that it is required only for urgent care basis. And for inpatient, yes, we have an updated implementation guide out there. For clinical registry, we have TNM, clinical stage observation, which is now actually separated into which is now more granular and separated into a nested series of these smaller templates. So the care is in a more structured way. We have three new measures that you see on your right hand side that are antimicrobial use and resistance reporting. We have healthcare surveys and we have electronic case reporting. So all these three new measures actually align with transmission of data to the PHAs using your CCDA documents, and these CCDA documents are more constrained based on the measures. So these measure titles are themselves self-explanatory. So let's go ahead and see what are the measures that providers are actually going to report. So here you see a dashboard out there where you can see what all are the measures that the providers are going to report to. Additionally, we also have CPOE, which is not mandatory with 2015 edition. So while you take a look at this automated measures, we'll just have a quick poll. Okay, so let's move ahead and see the second component of MIPS, that is quality. So with quality, what does EHR vendors have to do is they have to go ahead and report the clinical quality measures. The clinical quality measures also fall under quality, and yes, as we saw on our first slide, PQRS also falls under quality. So CMS actually merges both these programs together under quality, and yes, providers have to submit only these quality measures as part of both the programs. They do not have to separately submit both these programs, data for both these programs. So with clinical quality measures, EHR need to define their existing list of CQMs that they got certified for in 2014 edition to move the focus away from those three NQF domains that everyone always struggled with and as it was required in our EHR incentive program. So vendors would now have to wisely choose the measures that fit in the requirements of the clinicians. So the requirement here is there are two ways that EHRs can go ahead with. The first one is choose the measures that you already have implemented in 2014 edition. But yes, this time please make sure that you choose at least one high priority measure or one outcome based measure. And the second option is if you cater to a specific specialty, please go ahead and implement the complete specialty measures that CMS has given, has made it available on the QPP website. So these measures are categorized into specialty measure sets to ensure that the right measures are selected during the reporting. So this actually demands that the EHR vendors implement new measure sets from the scratch, because from our experience that we have seen is most of the implementations, the architecture design is not that flexible or that extensible. So this actually poses a major concern since these measures are going to get updated annually, and with annual updates every time, besides considering that you have to go ahead and update your existing measure list, you also have to make sure that if your providers are want to report to additional measures, you have to implement those additional measures also. So let us see what are the changes in clinical quality measures. So EHRs need to export QRDA category 1. We have a newer version for it, that is release 3. And QRDA category 3, there are not much major changes. I do see a question coming in from Steve Miller. Hi Steve, please go ahead. Yes, Steve, please go ahead. Hi Steve, you have any question? Please check if you are on mute.
Am I audible?
Oh yes, you are now.
Uh, yes, okay. I have a question for you. Will there be the same reporting system for ACI as there was for meaningful use?
So for reporting systems, okay, so for the providers, the answer would be yes. They still have to have their own EIDM account and manually go ahead and report to all those measures. If that was your question, then that's the answer for you for this, but please elaborate like if I have missed something.
I think that answers my question, and thank you very much.
Thank you, Steve. Okay, so we were at CQMs, so we were talking about the new updated version for QRD category 1. The import and calculate and so there's no major change. It is revised because we have to support the newer version for category 1. And we have a new thing over here that is filter for CQMs. So where providers can have this different filter options on the screen, and they can filter by the NPI number or say by specific problems or specific patient demographics. Let's move ahead and see the third component of of the MIPS and how does it relate to ACI. So the third component is nothing but improvement activities. So there are around 93 improvement activities that CMS has come up with in QPP. Out of those 93, CMS has picked these 18 measures, 18 improvement activities that actually relate with the advancing care information. So these are actually tied up to the objectives, the measures, and the cert functions of the ACIs. So all the measures that we implement with 2015 edition. And this is actually going to help the providers qualify to the bonus score of the advancing care information. So if they have reported it using the certified EHR, all these, any two of these improvement activities, they are going to earn that bonus score. So while these activities can be greatly enhanced through the use of certified EHR, we are not suggesting that that's the only way. There would be an additional step that the EHRs have to make sure and put so that can help the providers fit it within the workflow of the providers. So so there are a lot of activities here. We have 18 activities. I'll just pick any two of them in interest of time and elaborate on what the requirements are and how the providers can report to them using your certified EHR. So let's take the first one that we have, where the providers have to provide 24/7 access to the eligible clinicians or the groups or even the care teams for advice about the urgent care for the patient. And even the care team can access to a medical record. There should be a cross coverage with access to this medical record. It should be a protocol driven where the access of this medical records can be expanded within your practice hours. That is, expand the practice hours. There is a use of alternatives to increase this access, say use of e-health, e-visits, even the phone notes or group visits or home visits that can also be included within this activity. Now, how is this going to get impacted with EHR? So what do EHRs have to do? So we have implemented few of the measures, got them certified with 2015 edition. We have provide patient access. We have secure messaging. We have send and receive the CCDA documents. So these are the measures. If they perform these measures, they are going to meet this activity. But besides this, what is the responsibility of EHR is they can have this functionalities of telehealth services where actually that is going to help the providers give access to the patient over the teleservices. Yes, there are few other different functionalities that the EHRs can have to get a more improved care to the patient, and that can also fit the provider's workflow. So let's move ahead in our second slide, which has the next few set of our improvement activities. So let us take one of them over here, that is achieving health equity, where the EHRs, the providers have to leverage use of QCDRs to standardize the process and demonstrate the performance by reporting the activities using these QCDRs. So the process is screening for these social determinants of of health, such as food security, the employment, or the housing. So what EHRs can do here is have for the providers, where they can use these supporting tools that can be incorporated within the EHR, and they can report it using the public health agencies or the clinical data registries. So this is how the providers can achieve report to these improvement activities. So it is both the ways that it's the responsibility of the physicians to improve the care, but it's an equal responsibility of the EHR vendors to make sure that they comply to these requirements and help the providers meet these improvement activities. So before we move ahead and go to our next slide, we have a quick poll here. Thank you, everyone. Let's move ahead and see what's in our highlight slide. So highlight slide is nothing but our experience, our analysis on what we have seen, what meaningful use stage 3 or the 2015 edition demands from EHRs, and how much time is it going to take. So as you see on the screen, we have split we have actually categorized different measures into sections that are CCDA. We have FHIR. FHIR is nothing but the application access. We have PHAs. We have quality, and the fifth one, anything that do not fall under these four, we have marked them as a REST MU. So when we actually dig deeper, we identify that, okay, well, we have CCDA, we have FHIR, and we have quality. These are actually taking up 60% of modifications for 2015 edition. And based on our analysis, everyone is the EHRs would actually need 28 man-months for the development, complete development cycle till they get certified to 2015 edition. So let us see how can EHR vendors make sure that they have a complete system with these new features and the revised features updated, and what are the highlights in implementing them. So the first one that we have is the CCDA, that is the Common Clinical Data Set. So based on our experience, we have come up with an approach that builds a framework by use of this configurable engine, which contains the templates that are built based on the different sections within the CCDA. Say like we have the problem sections or we have the allergies sections. Read the data from the database, and there would be a data binding of these elements that come together, and the CCDA document is created. So this is the best, so far the best approach that everyone can go ahead and implement for the CCDA. The second one that we have is the CQMs. So the number of CQMs are increased, and if you're going to cater to more than one specialty, the list is actually going to get is going to keep on increasing. So the value list for these CQMs, as we know, get updated annually along with the measure QDM categories. So the methodology that we use here is to have a REST-based API call to retrieve the value sets information, bind it with the patient information, the clinical information, and have this all under a configurable category set to build up the to export these QRDA category files. So these are the QRDA category 1 and category 3 files. Then the third one that we see here is your application programming interface, that is APIs, the application access. So for APIs, we have used FHIR standards, and we have been using FHIR standards for all our clients we are working with, and we have identified that there are around at least a minimum of 10 FHIR resources that every EHR would have to implement, and there are more than hundreds of resources available in FHIR. So eventually CMS is going to make sure that everyone goes ahead and implements all these resources. So a framework and so a base architecture needs to be designed that will leverage and make sure that it is compatible with the newer resources and get easily plugged in with the EHR database for the exchanging of information. So these are the major highlights that we see in 2015 edition. Let's go ahead and see what is there in the EHR vendors tray and how much time are we actually talking about. So, even if we think of starting the implementation parallelly for different components over here, there are a few dependencies with these components. Say for example, we have CCDA. So before we start with implementation of CCDA, we have to make sure that we have the demographics or your implantable device list already implemented, and only then you can move ahead. So how much time are we talking about is, if you even start say by Feb or even by March, it is actually going to be by November that you are going to get certified, and that leaves actually only 1 month for your providers to go ahead and play around the application, and they actually go start reporting from next year. So considering this, we highly urge that you start the MU3 requirements from now, because analysis is actually going to take a minimum of 1 month, and then you start with your development, which is going to take around 6 to 7 months, and then you have the further processes. So considering this and making sure you're parallelly working, these are our estimates, and these are our timelines. So so that is where we are what we are talking about, that start your development from now. So that is it. We can go ahead. So this is the last slide that we have.
All right. Thank you everyone for your time and patiently observing the shared content. A recorded version of this webinar will be available on our website soon. So we'll share its link with all the attendees. You can anytime reach out to us if you have any questions or clarifications, and we will get back to each one of you personally and have those answered. Thank you once again. We would love to hear back from you. Have a good afternoon. Bye everyone.